Good morning.
One.
It's February 21st, Friday, and we are pivoting a little bit from our schedule. We were waiting for legislative council, so we thought that perhaps instead we would start with some bill introductions. So this morning, we're gonna have members of our committee introduce bills that they have sponsored to us. And we're starting with Representative
Francis Chopper McFarland.
Elko.
For the record, I just told you who I was. The first bill that I'm going to talk about is 8237. This bill proposes to authorize prescribing by doctorate level psychologists. The prescribing psychologist, just so you'll know how much this person has to do before they can prescribe. They undergo specialized training. They've passed an examination as determined by rule. They've received a current subscribing specialty. Under the prescribing authority, they can't dispense, administer, or distribute prescription drugs. They have to prescribe it. So they can't be in the office giving people stuff. There's a board of psychological examiners that is established that have certain powers and duties under this bill. A couple of them are, they adopt rules that govern the work of the psychologist. They establish continuing education requirements for the proposed prescribing psychologist. They regulate the length of clinical rotations that the prescribing psychologist has to do. They regulate the collaborative agreement that's between the supervising doctor. So this prescribing psychologist is under a doctor's observation for a couple of years. They have to complete 2 years of supervised practice, which I just told you about. It has to be 20 hours per week in a clinical setting that the collaborating doctor and prescribing psychologist agree on. They have to complete a national certification examination. They're not authorized to prescribe to people who are under 18 or over 80. They can't prescribe or administer a controlled substance by injection. They can prescribe some Schedule 2 and 5 controlled substances under specific instances. If the collaborating psychiatrist has gone through it with them, they make decisions together, and then they can prescribe those Title II or Title V drugs. July 1st, 25, the board is established, and by July 1st, 26, all the remaining sections of the bill take place. So it's going to take a year, but the board will be setting everything up in the meantime. That's the first bill.
That's question. Yeah, of course. So, Topper, just a quick, Representative Font. Some places in this bill, it says collaborating practitioner.
Yeah.
And I just wanted to understand
who that collaborating practitioner is as opposed to a physician, because you're saying physician, so
I thought I was saying a psychiatrist.
it doesn't say that in the bill. The bill
Oh, it
says
doesn't, but
practitioner.
well, I think
One example
that's what
is-
it's meant.
Page 5, line 3.
Well, okay. My understanding is they are going to be working with a psychiatrist. Now, if we take this bill out, we'll bust that out.
People love that.
Yeah.
I was just curious. Thank you.
In the definitions section, it does say collaborating practitioner means a physician licensed to practice medicine
So it's just a physician.
or other prescribing provider as approved by the board who generally prescribes prescription drugs for the treatment of mental health.
Okay, let me just tell you, in my discussions with the people that asked me to do this bill, they talked about a practicing psychiatrist.
Because there are psychiatric nurse practitioners who are prescribers and, very educated, and
Yeah.
maybe they want to include those. That's for our discussion.
Well, what we can do is, if we take this up, we can flush that out. We'll have them come in here and explain it.
Yeah. Okay.
Yeah, I think it's really interesting because I was thinking about this bill yesterday when we had in Northeast Kingdom Human Services, and they were talking about the wait times to get people into a prescribing psychiatrist.
That's right.
Now, granted, I think they were talking about children mainly, but this exempts the prescribing to children.
And-
But, we have an access problem.
Right, we sure do. And this bill, first, I introduced this a couple of years ago. It first came from an individual who had these kinds of credentials. And he was or still is, a constituent of mine. And then it progressed into a whole bunch of other people who are psychologists that have that doctorate piece, and they feel that there aren't enough psychiatrists to really provide the services that the people of Vermont need. So they thought it would be wise to do this kind of thing.
Be introducing it. What's your next bill?
Well, this is an easy one. This is an easy one. This bill, it's a bit changed right now, but this is a bill I submitted about 18 years ago, 19 years ago. And at the time, I couldn't get support from pretty much anybody in this building. And so anyway, I kept submitting it, hoping that it would catch on, but it didn't. But now that the hospitals are screaming global budgets, I said, maybe this is a good time to try this. This bill is kind of modeled after what happened in Rochester, New York, and Canada. Canada started their healthcare system in one province, and then they expanded. And so I figured, the hospital healthcare is the most costly part of the healthcare system. So why not kind of take that out and try this global budget experience and see what will happen.
Can I
Now,
interrupt you real quick?
yeah,
What bill number is this? I have 267, which is,
267.
I'm sorry, I thought 267 was on security within a hospital.
No, it's not security. I know yesterday you said, well, Ari and I have 2 security bills. This is, the security part of this is securing
Oh,
hospital health care
okay.
for everybody.
Keep going, sorry.
All right, so anyway, get the right piece of paper. Three things at least that happen in this bill. A hospital security plan is established, and that plan spells out how this will work and how people will be covered. There's a hospital security trust fund to finance this bill, and into that trust fund, it goes all of the Medicaid, Medicare money, all of the public money, and we have to get waivers to do that. But that all gets dumped into the trust fund, along with, well, let me tell you about the third thing. There's a hospital security plan special committee that's established to determine, make recommendations on where the money is going to come from to fund this. In the bill, there's there's 4 or 5 recommendations of where they should look for sure. Things like the payroll tax or an income tax. And so you get this hospital security fund and you fill it up with this money. And you and I go to the hospital, we receive the services that we need, and we go home and we don't worry about a hospital bill. The hospital bill is paid out of that security fund that's administered, I think it was by the Agency of Human Services. There'll be a negotiated statewide, covering all the hospitals, a global budget for hospital healthcare. From that statewide budget, each individual hospital will negotiate for the amount of money that they need to run their hospital. And that will come from that overall state budget. And that pretty much is how this thing works. Now, I will tell you this, there's going to be a lot of questions about this. I experienced them. When I first did this, my wife and I traveled the entire state of Vermont in the summer and fall in between sessions. And the first night that we spoke to people, I think there were 4 people there, including me and a doctor. By the time we finished, late in the fall, it was ice all over the place this particular night. And we were up in Craftsbury, Vermont, and we were in the Grange Hall. And the stage was full of people. The hospital association, doctors, nurses, nurse practitioners. And the building wouldn't hold the amount of people that were there to listen to what we were talking about. There is, I don't think anyone's going to dispute that we need structural change in hospital healthcare. And we have to make sure that people have a hospital where they can receive their services. I don't think that's going to be an issue. The issue is going to be how do we pay for it? And there's some good ideas in here. And if we take this thing up, I guarantee you there will be tons of people that will want to come in here and talk about it. And I personally think that we need to do something soon. We need to get something going. Not that I'm against the AHEAD program, but the AHEAD program is going to be too bureaucratic. We need to get into this thing and get something started. And if we choose to do it, I know you're going to have a lot of people that are against it, but you're going to have way more people that are for it. And now that the hospitals are interested in global budgets, That's what the backbone of this thing is. It will cut down on different hospitals having different prices, et cetera. It'll bring that cost, it'll stabilize it, and people will have access. So open up with the questions.
Can I?
Wendy,
So I did see that it said that this is definitely for Vermont Hospital, so any network that would have a hospital outside of Vermont would be exempt from what your plan?
That's right.
Okay,
But if you go to a hospital outside of Vermont, it's going to get paid for.
okay,
through the trust.
If a person comes into Vermont from outside, they have to pay for it.
okay.
I have a question. Did you consider expanding this to all care, not just hospitals?
Yes, I did.
And
And I felt that that's already been a loser here in Vermont. And that's why I stayed with, because I always thought that if we start with a little bit, we start with a piece of the healthcare system and stabilize it and make sure that it's taken care of properly, then we could move on. I know there's a bill for primary care. There's a universal healthcare bill for everything. I'm signed on to them. I believe eventually we got to get there. But I just feel that this is the way to start it. It was very successful in Rochester, New York. The reason why they stopped doing it, very honestly, from the information that I got from the research that I did about that, is because the doctors and the hospital wanted to get paid more. And the global budget was preventing that, but it did keep the costs down.
and it's only, right now, it only includes Medicare and Medicaid, not
No.
commercial?
No, it includes all of the Medicaid and Medicare money that is spent on hospital care. And that committee that I talked about that's set up, they have to make recommendations how to finish funding this thing. They, payroll tax, income tax, they're gonna research all of that and figure out where money can be raised to fund this. And when I did this before, the Joint Fiscal Office, they had it all laid out and it was possible.
We can get that done in a couple days, right?
Like if somebody's, it's got Medicare.
Yeah.
Since you said, for all.
Yeah.
Okay, so if they pay a certain amount and there's still some pay left, they would take care of it regardless of what you got for insurance.
That trust fund will have all of that money that was collected from Medicare and Medicaid that they spent on hospital care, plus the money from whatever other way that they want to, that committee just recommends to fund this.
Yeah.
And yes, the answer to your question is yes. You won't pay
No.
if they have some kind of a copay that they
That's what I'm
decide.
saying, yeah, copay.
Yeah, you pay the copay and that's it. But you go home and you're not gonna be worried about going bankrupt, or you're not gonna be worried about paying that bill.
Thank you.
Could be foundations that put the money out. I don't know. It's up to that committee
Yeah,
to
yeah.
come up with that
No,
plan.
the committee, would that be a paid committee?
I think in the bill, it spells it out. I think that, if I remember right, there were two people from the House of Representatives.
Yeah.
Okay, well, you got it right there.
I can get that
There are, the committee is,
stipend of some sort.
yeah, I don't know where it is in the bill. but I think there were two people from the House of Representatives, the Senate, and then there were others. I honestly can't remember where it is. Two members from the House, one from the House Committee on Healthcare, one from the Committee on Ways and Means, appointed by the Speaker, two members of the Senate, one from the Senate Committee on Health and Welfare, and one from the Senate Committee on Finance, appointed by the Pro Tem, the Secretary of Human Services, Commissioner of Taxes, and then it spells out their duties. It talks about some of the places where they can look for money. I think it's a great idea.
Cindy?
I don't hate this at all.
You know, you talk to your constituents and they'll tell you they don't hate it either.
But where does, commercial insurance fit into this? I'm losing that.
Well, let me tell you where commercial insurance fits in Canada and Europe and every other place that has this. They have private insurance as well, if they want it. You as an individual can purchase it. And let me tell you how I know that. Personal experience in my family. Heart attack took place. Went to the hospital in England. They were put in like they were stabilized and put in a holding ward, waiting for the specific heart doctor. The minute the commercial insurance was put on the table, because they were there for 2 or 3 days and said, no, let's get this thing done. The commercial insurance was put on the table and that same doctor did the operation within the next couple of days. So commercial insurance will have a place if people want to buy it. But they're going to have insurance anyway, because the other, primary care, doctor's visits, stuff like that, you're going to have regular commercial insurance for that.
But wouldn't it fit into this pool somehow?
Well, they're private companies and you can't dictate to them how they.
Would this allow people to buy into the Medicaid? So people would be buying into the pool?
Not for, no, that's not part of it.
Yeah.
The Medicaid money
Yes.
that is spent on hospital healthcare only.
Yeah.
Is the Medicare and Medicaid money that will be put in the trust fund.
Okay.
But you gotta have a waiver to do that.
I'm just wondering about like all the people with commercial insurance, if they end up in the hospital.
Yeah.
Commercial insurance would pay, kind of like what they do now.
If they kept the same kind of commercial insurance that they have. But what they may do is say, okay, hospital healthcare, I don't need that anymore. So here's the kind of insurance, the insurance companies are gonna have to figure out a way to fund the rest of it.
Okay. All right.
They're not involved with this particular trust fund yet. They may want to get involved, I don't know.
All right. Any other questions for Representative McClellan? Thank you. So
Remember to talk to your constituents about
I admire your tenacity.
Get back up here. 18 years, right? You know. Representative Curtis, would you like to?
it. It's a common sense.
Yeah.
Oh,
You borrowed it. No, I got it back.
Can I borrow somebody's plug? My computer's about to die.
One phone.
Thank you. Oops,
It's yours.
in 5 minutes, I'll switch over here.
You're fine, you're fine.
So Representative Cordes, I have 3 bills for you. First one is H202, another pharmacy bill that moves us a little further down the road from the last bill that I introduced and passed on pharmacy benefit managers. H233. H202, the subject is on health insurance, prescription drugs, PBMs or pharmacy benefit managers, hospitals, and the 340B program. So there were in H233 last year, which was passed and signed by the governor, was focusing on regulating PBMs. And there, we did do some work with the help of the Office of the Healthcare Advocate on consumer protection. So working with the Office of the Healthcare Advocate again, and the ideas for this bill actually were generated by the HCA, focuses more on consumer protection. And in general, would do more to protect consumers from the abusive pricing distortions present in the market, largely because of pharmacy benefit managers and their negotiations and deals with drug manufacturers, and how much is of those negotiations and rules and anti-trade practices are kept behind a black box, and it's hard for us to get at, why drug prices are going up so high because of all of these different machinations behind the scenes. And then I'll go into a little bit more detail, and then another part of this bill would does focus on increasing transparency around the money that hospitals it's about the 340B program. So increasing transparency of the 340B program, which was initiated many years ago to help support hospitals that were providing care to low income folks. So the hospitals could purchase prescription or drugs, medications at a much lower cost. And then now the 340B program is actually supporting, is part of what helps support hospitals, because hospitals can charge more than what they acquired the drugs for, which is, in the seems like a reasonable thing to do. And we want to, this bill will get at just how much money are hospitals making from the variation in price from what they actually spend on getting those medications, and what they're charging, and what are they, if there is extra additional money from that practice, what are they using it for? So that's the overview. This first section gets at one of the practices of there are many different terms around drug pricing. One, a maximum allowable cost. NADAC, the National Average Drug Acquisition Cost, and that the NADAC is actually, we believe, a fairly fair measure of what to base an actual drug cost on. And so we want to use that NADAC as a baseline plus a professional fee. And some of you may remember last year in 233 and the PBM bill before that, we tried to do something similar and use this pharmacy stuff is so complicated, and I'm trying to make it simpler, and use a dispensing fee. So that, for example, many pharmacies, and the reason that our community pharmacies, independent pharmacies have gone out of business is because they are, what they're paying for the drugs is not getting compensated for by the insurance plans because of PBM. So they may actually lose money for dispensing a medication. But again, the focus here is on consumer costs. So we want to make sure that consumers pay just the NADAC price plus a little bit of a dispensing fee, so that or a professional fee is another word for it. So the pharmacies can continue to do business, the insurers can continue to do business, instead of some wildly inflated fee on top of some other measure of determining a drug price other than the national average drug acquisition cost, which again, we think is the most reasonable and standard way that should be done. And then it would also add clarity to the definition of a drug's cash price by saying that the cash price includes the lowest possible price for an individual by using a drug discount card. And I might ask, if you have questions about this, I might phone a friend over here. It would close the discount card loophole by making sure that when you go to the drugstore that you can get that discount card price, which often might be better than the price that your health insurance plan would have. And that, again, would still count toward accumulating the numbers and your deductibles and out-of-pocket maximums. As I mentioned earlier, there are multiple ways that drug prices are used in the market, and some of it's behind in that black box. It's often used again for antitrust profit, and instead of being of benefit to people that need to purchase their medications. So Section 2 would ensure that patients are aware that there are multiple prices. So they're getting at all of those different definitions I was talking about. The cost share price, the maximum allowable cost price, the cash price, the NADAC plus the professional fee price. This Section 2 would say that the consumer should pay the lowest of any of those prices. And it would also require that pharmacies post a notice informing consumers that they can ask about the different prices. And I would recommend doing that now too, personally, when you go to the drugstore. Sometimes I just prefer to pay out of pocket because it's cheaper than even the copay for what my insurance plan covers. And then more on consumer protection. So when you get medical claims or when you have medical claims, your insurance company sends you EOBs or explanation of benefits. But you don't get that with pharmacy claims. And that's because your insurance plans receive pharmacy rebates and discounts after the claim has already been paid. So consumers, especially those with chronic conditions, can be led to believe that their health plans pay a lot more for their care than they actually do because of these rebates and discounts. So this Section 4 would require disclosure of that and accurate information about how health plans report drug spending to their consumers. So we should know how much our health plans are actually paying for their prescription drugs after rebates and other discounts. And that was it, we've identified that in the last few years in the PBM work that we've done, that there are also times when even health plans didn't know what pharmacies were paying and being paid for medications. In an aggregate way, they knew, but not on a drug by drug or a claim by claim basis. They didn't know. But it's important for consumers to have that information. So health plans must notify on an annual basis how much their pharmacy claims actually cost. And then section 3, this gets at the 340B program. And just simply, we require hospitals that participate in the 340B program to annually provide data to the Green Mountain Care Board about their participation in the 340B program. And Charlie gave me information here. The 340B program was created by Congress in 1992, so it has been around for a while. And this would apply just to Vermont hospitals, excluding smaller providers like federally qualified health centers. And the things that they would need to report to the Green Mountain Care Board would be how much revenue they generate from 340B, how much they pay to third parties. Often they are for-profit third parties to facilitate the hospital's participation in the program. And then to describe how they use that revenue that they get from the participation in the 340B program, how they use it to benefit their communities. That's H202.
Great. Thank you. And honestly, thank you for introducing this and all your work on this. A lot of work.
Yeah, Marie. I'm grateful to
The
the
chipping away at a thing every year.
It's really grateful to all of the folks that have been working on this for so many years, the pharmacists and Office of the Healthcare Advocate, obviously focusing on consumer protection.
Okay, so let's pivot right now
Sounds
to
I've got
H96, since we have legislative council, and then we'll come back.
do the other ones after Jen.
The other ones after Jen. You admire your color.
I know.
So I wanted to do a last review of H96 and votes on this. But I will say that I've heard concerns from other members of this body, particularly around the piece for the exemption for state grant or state awarded facilities,
No.
an exemption for them to go through the CON process. So I asked Jen to draft some language that she could put before us for consideration. And then we can talk about that then. So I know you're gonna review the bill, but just to let everyone know why that's in there.
Can't seem to clean it up on our.
It works if you go to today.
Our
Point one.
Yeah, I got
You're special.
no, 2 points. You got 1 point.
You were able to hold on?
Oh.
We got to one side of the table faster than the other.
If Woody can get it, he can show me.
Let me just make sure.
Let's go back.
I can refresh.
Jim, is the last one, the one that has the yellow on it, the last, when you did the other day?
Which,
No, that's one, she's a 2-1. The one we're looking at is 1.1.
we're looking at 2.1, we want 2.1.
We're back.
Let's just go back to the very beginning.
So again, as they organize, I told Wendy about the house deadline.
We're on,
I think it just.
we're on 5, so maybe we'll talk later.
Forgot.
Go right.
Thank you.
Go ahead, Jen.
Okay, Jennifer Carby from the Office of Legislative Counsel. We are looking at H96 draft 2.1. And this is still an act relating to increasing the monetary thresholds for certificates of need. I took out all the yellow from what we looked at yesterday, so it should be clean until we get into pages 6, 7, 8 around there. So we have the monetary thresholds in section 1 should be the ones that you are expecting. We also have that language about a new healthcare project means any of the following rather than includes the following. All of that has been incorporated into this draft. The new language starts on the bottom of page 6. This is where we're in section 2 under exclusions from the certificate of need process. And this draft would delete the exclusion for the for projects that are for facilities or health services owned or operated by the state or funded in whole or in part or substantial part by a contractor. Oh, I didn't put it up. Oh, I'm scrolling through it. Thank you.
We're following you there.
I was scrolling through, so I wasn't even looking.
Thank you. No, I was scrolling through it like it was up there and it was not up there. All right, so we're on page 6. And so this would take out of the exclusions, that exclusion for the contracts or grants awarded by the state, and instead, and just re-lettered the following one as I, and instead would create or put them under an expedited review process. So in the existing law, there are a few places where there is an expedited review mentioned, but the cleanest place to add it seemed to be in the existing provision around information technology projects. And so I added in state grants and contracts. And so it's under existing law, notwithstanding the procedures in section 9440 of this title, which is the regular CON process and the expedited process with its own sort of exceptions. The board shall establish by rule standards and expedited procedures, which they have already in their existing rule, for reviewing applications for, and now I've broadened this from the existing IT language, for the following projects that would otherwise be subject to review under this subchapter. And I actually broke the earlier one out. It was bothering my ear a little bit, this idea of a healthcare service that is owned or operated by the state. And so I separated these out. So it's the construction, development, purchase, renovation, or other establishment of a healthcare facility that is owned or operated by the state of Vermont or is funded in whole or in substantial part by a contractor grant awarded by the state of Vermont. And then the offering of a healthcare service that is funded in whole or in substantial part by a grant or contract awarded by the state of Vermont. And then we keep the existing language, the purchase or lease of health and care information technology. I moved this part about otherwise subject to review up to the introductory language, and then kept this concept that the board shall not grant or approve a healthcare information technology project unless the purchase or lease is consistent with the health information technology plan. And under existing law, it also says the health resource allocation plan, but I'm having that language now apply to the whole, to all of those items, the state funded and HIT. So an application reviewed pursuant to this section shall not be granted or approved unless it is consistent with the health resource allocation plan. And this was and the statewide system of care. And so the expedited process that the board has set up and to some extent is addressed in section 9440 does allow for public comment It does require that it allows for an expedited or an abbreviated application, so it's not a full application. The board obviously would be able to determine the scope of what it would look like for these state projects. But it's my understanding there was interest in having some opportunity to look at how they fit with other facilities and projects and services that are being offered. And so this, I think, is looking to find sort of a middle ground with an expedited review. So it's faster.
This allows an expedited review if they find that it is in line with the consistent with the health resources allocation plan and the statewide system of care.
So I'm
If it's
getting a
not,
slight,
it has to go through the regular review.
no.
Oh, okay.
So I'm gonna clarify. So no, this only triggers if the monetary thresholds are met. And then this would have an expedited review for these state projects. It can only be granted, the CON could only be granted, certificate of need only granted if it's consistent with the health resource allocation plan and the statewide system of care. So it would only be an expedited review for these projects, but the application would not be granted, the certificate of need application, unless it was consistent with the, kind of abbreviated to HRAP and statewide system of care.
Okay, I have some questions about that, but
What's this statewide system of care?
It's currently, it's more sort of conceptual, but just, looking at balancing, it's sort of the HRAP, except the HRAP hasn't been updated recently. So just looking at whether and where and how services are offered around the state.
Okay.
And there may be additional, I'm also trying to sort of balance work that's going on in Senate Health and Welfare that we may end up with terminology to use, but for the moment, I think this, in talking to people who were concerned, some of the concerns kind of went along with, or is this consistent with direction we're trying to go in having a statewide system? So there isn't a specific thing, but more the concept of how we deliver care in the state.
Daisy, was that your question?
That was exactly my question. I wonder if it's a state health improvement plan.
I think
Is
that's
that too
different as
HHS?
well.
Okay, got it.
So lots of plans,
Got it.
lots of.
Robert, I will get to you, but I wanna, doesn't this actually make it more stringent for a state? Because now it's just completely denied if it's not consistent with the HRAP and statewide system of care, as opposed to something that would go through the normal, long contracted or protracted CON process, where it doesn't necessarily have to meet just that criteria. It can meet it can be approved for other reasons. I'm thinking, doesn't this just make it more restrictive?
I'm not sure it makes it more restrictive. It makes it a more streamlined process. I think the HRAP is already part of I'm just looking. So I think the HRAP is already part of the criteria. They're supposed to consider the HRAP. Oh, no, that's somewhere else. I'm trying to look in the whole chapter. So yes, so they already have to be looking at a number of things, including the board finds that the project is consistent with appropriate allocation of healthcare resources, including appropriate utilization of services as identified in the health resource allocation plan.
So does it say that they shall not grant it or approve it? Is the shall in there, or is it that these are the things they
Well, the
may
language,
consider?
the existing language says a certificate of need shall be granted if the applicant demonstrates that the project serves the public good and the board finds, and then there's a long list. The proposed project aligns with statewide healthcare reform goals and principles because the project takes into consideration healthcare payment and delivery system reform initiatives. addresses current and future community needs in a manner that balances statewide needs if applicable and is consistent with appropriate allocation of healthcare resources as identified in the HRAP, and then a number of other things. So it shall be granted if the applicant demonstrates that the project serves the public, if the board finds that it is consistent with the HRAP. So yes, maybe in a
There's nothing
backward.
that says they shall not, if it doesn't align perfectly with all of that.
So I'm happy to change the language. If there's interest in changing the language, I was asked to bring some language in.
Topic, did you have a?
Just so that I'll understand it. The State Psychiatric Hospital in Berlin, if they wanted to expand, they own the building. And, we know there's a need. So they say, okay, what we have to do is expand the hospital. How would that affect them? How would the way it's written now affect that building?
So it would need to be an expansion. I believe the threshold on the expansion is still, well, if it's in the number of beds, expansion in the number of beds, I guess it would trigger it. So there would be an expedited review and the board would go through their expedited review process. I believe I would want to defer to the board on their jurisdictional determination, but
Through that process and.
so under current law, they would have to go through the full CON process if they hit the monetary threshold. Under this language, they would go through an expedited process, but there would not be an exclusion or an exemption.
And if they had to abide by the health resource allocation plan, which is not updated, what would happen? Would they quickly update
I can't answer that question. I don't. I mean, the existing language of the statute requires the project to be consistent with the health resource allocation plan.
when's the last time, Jen, just out of curiosity, that thing's been updated?
I don't know. I don't know if the healthcare advocate, do you know when the last time was the health resource allocation plan was updated?
I do know one thing, they do it in sections.
2020?
But it depends on the section, right? Because the substance abuse section was done. So there are different sections that they update in some order. So if we go to their website. you can
Yes, I'm
see-
looking at their website
Yeah.
right now.
Okay, so since they do it by sections,
Yeah,
so.
you're behind on primary care, I know that, and that was one thing that I asked, but they
So,
take it down.
I'm just trying to, I'm trying to eliminate barriers is what I'm trying to do. And that could be a big barrier. Especially with the situation that we're in with mental health services.
Well, I think to some extent, that's where having the statewide system of care language is helpful. Because to the extent the HRAP itself is not current and the board is not comfortable basing a decision solely on an outdated health resource allocation plan, it gives them the ability to look at the statewide system of care.
So the system of care thing would take over then.
I mean, that's in looking at it, that's, I think, a reasonable read, but you may want to hear from the board since they're the ones who.
Just lost my thing here.
It's okay.
Is the word or, is it the statewide allocation plan or the system?
No, but I think
It's and, isn't
it
it?
is and.
Yeah.
But if they are not, if the statewide system of care is more current than the health resource allocation plan, I think the board uses its discretion in what makes sense.
Stacy, I'm sorry, because I'm thinking.
Just a comment. I don't think consistent is a very precise word. It's an observation I'm making. being consistent with something is very debatable. So I'm really comfortable with this section in B because I think it means that whoever is doing the review needs to be mindful, and whoever's writing up the plan needs to be mindful that it's aligned with those two things, right? But it's not, it doesn't have to be accurately in step. So I don't see that as a barrier because consistent just make sure that they're referencing those. Do you know what I mean?
Oh, yeah, I know what you mean. Okay.
I mean, we
I
could-
just
and I
don't
don't
like
wanna
that they
let
have to
it-
do both.
I know, but I don't want to let it be, perfect be the enemy of progress, is what I'm saying.
If it had all, that would satisfy it for me.
Well, but that's either or. That may mean it's consistent with something that is not current.
But it would be
I
consistent.
think we could say if it is inconsistent with, if that makes people feel more comfortable, shall not be granted or approved. If it is inconsistent, if the board finds it is inconsistent with one or the other.
That's what I'm actually struggling with is, the sort of,
So it won't be granted or approved if it is inconsistent with.
Right, we
each
could
one.
say if it is
is that better?
inconsistent.
Yeah, that's cool. I was just hung up on the definitive nature of shall not, along with the sort of squishy nature of consistent. It's the best way I could
Well,
put
now you
it.
got inconsistent. That's a little bit less switchy.
Okay. And I like the or. Yeah. Yeah, honestly, I mean, Jen just did this drafting very recently and I was not thinking, but I think we might want to hear from some interested parties, so I'm happy to look around the room for anybody who would like to give their opinion on this. Devin, do you wanna?
Yeah, Debbie Green, Vermont Association of Hospitals and Health Systems.
No, do you want to interrupt?
Oh, would you mind?
I don't have this list.
I'm okay.
Really appreciate all the work that the committee's done on this bill. And also appreciate the consideration on the state projects, and grants for projects. We like the funded in whole or in substantial part language. I think that makes a lot of sense. We would want this to be an exemption, again, for the reasons that we stated in terms of, and if you want to split that up between, if you are worried about state projects, that maybe are not going through the legislative process or that sort of thing, but we think that when the state has created a budget, brought it to, has done an RFP, has brought it to the legislature, has gone through the legislative process, that usually indicates an urgent need and that project should move forward. Also, again, I think that there will be, I think the CON as it stands now, even with the accelerated process, creates a chilling effect to private organizations wanting to do state contracts at this point. So an exemption would be really helpful there. I also think the statewide system of care language is pretty vague when we try to understand what that means legally and develop our certificate of need. I think with the health information technology plan, that should be addressing our statewide system of care. The HRAP should be addressing our statewide system of care. It's a it's all of our healthcare resources. So adding this additional piece just creates greater confusion and perhaps longer delay.
Does the current RFP process, legislative appropriation process allow for robust public input?
Yes, I would argue that it does. I think with the RFP process, I know that there's an opportunity for questions in that process and for the state to change its RFP. And I think with the legislative process, even more so than the certificate of need process, is much more public. The certificate of need process, of course, is public, but the legislature is much more high profile than, very small regulatory process. So I would think that that would actually get at the statewide needs piece that you're seeing here.
I mean, I think both of those processes have, a mechanism for public input. But does it provide anything with public power within the process? Or does it just have here you can voice your displeasure or your pleasure?
Well, I think the public power in this building is pretty great. People who come in and testify one after the other very often sway a bill to go one way or the other. So yes.
If this remained in the bill, would the Vermont Association of Hospital and Health Systems be opposed to the bill or?
So I've just seen this language. I haven't talked to my members about it, and so I would want a chance to consult with them.
Does anyone have any questions for Devin? Would our healthcare advocate like to?
Good morning still. Mike Fisher, healthcare advocate. So I just first off, reminder that the HCA's position was to not exempt state projects. This is an interesting attempt to find a middle ground, to find a faster process. My initial thought, as you've heard me say over and over again, sometimes CONs take too long anyway. But I also want to respect that the Green Mountain Care Board has come forward and said that they think that they can speed things up. I guess I want to appreciate attempting to find a middle ground for how to address state projects. With all due respect, the legislature is a very careful, deliberative process until it's not. And we all know that. So that was that. I want to be. I want to recognize I've been on all sides of this and know it very well. This can be as the best process in the world for really evaluating the advisability of a public policy, and it can be as far from that as we all know.
Do you have any thoughts or comments about the public input during the RFP process?
Yeah, I have no idea whether, and people probably fall on all sides of this, but in the RFP process, would somebody who believes the project would affect their business and their viability have an opportunity to comment on another party's RFP? I don't know it well enough. Hard for me to imagine. Because it was just a public process, it's hard for me to imagine, and correct me if I'm wrong, but hard for me to imagine that the Brattleboro Retreat would have had an opportunity to comment on SVMC's RFP in the way that they had an opportunity in the CON.
But they could.
I don't know enough to answer that question. I guess what I mean to be saying is I suspect it would. I suspect in the process that just occurred for the Green Mountain Care Board for that project, that the retreat had a greater ability to comment on how the project affected them. And whether you want to allow for that or not, I'm just. Appreciate the creative thinking.
I know you had already gone on record that you didn't think that state projects should be exempted, but do you think that this is better than it was?
The inclusion of this language would not change our support for the bill, if that's the question you're trying to ask.
No. Okay.
What does that mean, Mike?
I
you just said?
was just wondering about putting him on the spot or not.
On the whole, I think the bill, increasing the thresholds is a good, on the whole, I think the bill is a good bill and the HCA supports it. The public projects is a subset of that, and the HCA stated its case on that. This detail doesn't change our support for the bill.
Does this detail?
I can win some and lose some, and it's okay.
Does this detail make the Office of the Healthcare Advocate feel a little bit better than with the exemption as it was?
Yeah, yes.
Thank you for that.
All right. Thank you. Woody, do you have a question?
Yeah, I have just a couple of questions. One, CONs are nice. Personally, I think we should do away with the CON. I know that's not gonna happen, but that's my opinion. The one question I have is, can the board disapprove a project if it meets all of the financial criteria? Does it have that ability? And what would cause the board to not approve CON if the project did meet all the monetary requirements?
When you say meet the monetary requirements, are you saying if it's over the threshold or under the threshold?
Yes. If it's under all the monetary requirements.
Larry, I just said, join us again? Sure. I'm sorry to keep making you walk back and forth.
Jen Farby, Office of Legislative Counsel. So if a project is below the monetary thresholds, it doesn't trigger the CON review.
And the board has
So
no potential project.
I mean, under the existing law, the language says includes those monetary thresholds. So there is, arguably, this is what we've talked about in the past, arguably the ability for the board to review something that is under that threshold. But I believe their written testimony suggested they have never used their authority or interpreted it in that way. So no, they do not.
Okay.
They do
That's
not
good.
assert jurisdiction below the thresholds.
That's all I have.
Okay. Does anyone have any questions for, Jen? I would like to vote on this, but I'd like to take a break first.
Well, can I
Oh, yes,
ask one other question? Yes, towards the end, and maybe this is what we're all talking about, the exemption. The hospital, Rutland, that's currently working on a project. Can it, the project that it's working on, and I know they've done some CON work. And since their project is below the threshold of what we're talking about here, financial threshold, do they have to do any other CON work?
So the way the effective date language reads is that it would, the changes, the higher monetary threshold and otherwise would apply to new healthcare projects initiated on or after July 1st, 2025. And if a certificate of need application is already in process, then the lower jurisdictional thresholds would continue to apply until a final decision is made. So if a project is currently in the CON process, it would finish out the CON process. If a project has not been proposed yet, it would.
Is there any way to get beyond that? And, basically say.
I need you to finish the question.
I don't know how to put it in.
Is there a way to get them out of having to finish the CON process? Is that what you're asking?
Yes.
I think, I was looking back at ways that we have done applied changes to the CON process in the past. Some of them we've done like this. I know there was one that was, circumstances were a little different, but it was changing jurisdiction from over the transfer of nursing home ownership from Green Mountain Care Board under the CON to something at the Secretary of Human Services level. But in that case, I believe we had given the applicant the option to continue the existing process with the board or switch over. So I think we could look at giving an applicant the opportunity to withdraw
and just
and
continue.
continue, right. I'd want to talk to the board folks about whether they saw any issues with that. But I think this is an option. I don't think it's the only option.
Is that something that we could consider? Chair?
Yes, it is something that is considered. Yeah, absolutely. And I will amend, I'm going to wait until this afternoon because I feel like I'd like to hear from some other people.
Yeah.
On this. Okay?
Thank you.
Alan, did you have a question?
Well,
And then
kinda.
yes, Leslie, I do see.
If we're trying to make this process easier, is this being consistent or inconsistent? Which is it going to do?
I'm not sure.
The process, okay, the CON is supposed to be making the process easier for, the 5 million or the 3 million. And this section here, the number B, the applicant review pursuant in section shall not be granted or approved unless it's inconsistent with the health
If it
resource.
is.
But now that's a question. Are we inconsistent or are we consistent at this point?
So this is section 3. This is the subset of projects that are as the result of a state grant or contract or relate to information technology. And it's allowing an expedited CON process rather than the
Right.
full CON process for projects that trigger the monetary or other thresholds. And then it is saying an application reviewed under the expedited process shall not be granted or approved if it is inconsistent with the HRAP or the statewide system of
So
care.
that's the writing now is inconsistent.
Yes, but so it will not be approved if it is inconsistent. Which is, I think, it makes it easier for an applicant than having to show consistency. They're having to sort of show that they are not inconsistent.
Leslie?
I just want to thank you for this language. I think it's good middle ground. I was someone who had concerns about just this blanket exemption. And I think this allows a path which takes the whole plan into account, the statewide plan, local context, and I think that's important. So I just want to thank you for sort of creating and evolving this thing.
And Chair, I don't see any personal interest in suggesting that amendment, other than we did hear testimony from the Rutland Hospital and what they were doing. And I just thought of this particular idea as we were discussing.
Yeah.
Just want to be on the record.
Yeah, okay. Just so I understand, Woody, Rutland Hospital is not owned by the state.
No, I know that, but what I was saying was, since they're in the process of doing their CON work,
Okay.
if
So
they.
you're talking about all of those that are.
Effective date.
Yes, yes.
I think that we are gonna end for the morning and come back at 1 o'clock.